Hello everyone, welcome back. Today I am going to cover regarding segmental bone defects. We started off with an introduction regarding Masquelet technique, regarding distraction osteogenesis and its example, the advantage and disadvantage of each bone transport technique. 6 of them. Thank you. As an introduction, segmental long bone defects are some of the most challenging to surgically reconstruct. The common definition for segmental bone defects are a defects 2 to 2.5 cm times greater than the diameter of the injured bone, or a defect in the bone that is too wide for spontaneous regeneration. The two main techniques for reconstructing segmental bone are the induced membrane technique pioneered by Masquelet and distraction osteogenesis introduced by Illizarof. Masquelet noted that by inserting a polymethyl methacrylate spacer PMMA for 6 to 8 weeks in a segmental cortical bone defects induced the formation of a periosteum-like membrane which provided a better space into which autologous cancellous bone graft could be protected from resorption. These two-stage procedure and variations are referred to as Masquelet technique. Several modifications of the distraction osteogenesis technique have been described, including bone transport over an intramedullary in IM nail, bone transport with a plate, bone transport with a plate and intramedullary lengthening nail. Regarding Masquelet technique, the general steps of Masquelet technique are well established, but the details of the procedure are variable and dictated by surgeon preference and patient condition rather than evidence. During the first surgery, the bone is stabilized and the diseased or injured tissue is removed. The resulting bone void is filled with polymethyl methacrylate PMMA, which is molded to fit the defect before it hardens into a bone cement. This picture illustrates the filling of bone defect with polymethyl methacrylate PMMA and soft tissue coverage. Whether the antibiotic is included depends on the surgeon preference. Infection clearance is necessary for success, so the polymethyl methacrylate PMMA is often supplemented with antibiotics. Limited evidence indicates that antibiotics have no impact on membrane formation, but Dr. Masquelet recommends addressing infection via a thorough debridement. Internal and external fixation are both utilized according to the surgeon preference. This picture depicts the membrane PMMA polymethyl methacrylate with bone graft in situ and later the bone remodeling occur. You can go and see my previous video regarding a Masquelet technique. This figure illustrates an overview of a Masquelet-induced membrane technique, MIMT. MIMT is a two-stage procedure. During the first stage, surgery is performed to remove the damaged or diseased tissue, a fixed fixation device, and implant a polymethyl methacrylate PMMA spacer. The following convalescence is used to allow the body to create a foreign body membrane surrounding the spacer, but also as a time to treat the infection. In stage 2, during the second surgery, the spacer is removed and the resulting tissue compartment is filled with morcellized bone graft. Healing occurs over the following month. The interval between the first and second surgery from 4 to 96 weeks. Ideally, you should monitor the serum biomarkers, example the matrix metalloproteinase, MMP, insulin-like growth factor 1, IGF-1, and platelet-derived growth factor, PDGF levels. This will help inform decisions on timing of the second surgery or possibility of a failed membrane formation. Next, regarding summary of bone transport technique that is used, I will start with A. Distraction osteogenesis by Illizarof method. The advantages of this technique include it enables simultaneous lengthening and correction of the deformity. No requirement for autologous bone graft techniques, thus eliminating the donor site mobility. It allows the patient to bear weight with an external fixator during the treatment. It is an effective treatment of complex infected non-union. This picture illustrates an Illizarof frame that previously was described in my previous video. The disadvantages of Illizarof method are complications related to external fixation, pin-related infection, broken wires requiring reoperation for frame revision, joint contractures, psychological and physical distress caused by prolonged external fixation time. This picture illustrates how Illizarof method is used as a distraction osteogenesis. B. Bone transport using a monorail fixator over an intramedullary nail, IMN. The advantages of this method are interlocking of the transported segment protected the regenerated callus. External fixator can be removed once docking has occurred, thus reducing the external fixation time. Increased stability of the intramedullary device, thus reduces the stability required by the external fixator. This picture illustrates the X-ray of the right tibia and fibula with the bone transport using a monorail fixator over an intramedullary nail. The disadvantages of this technique include difficult insertion of half pins. Half pins cannot touch the nail. Readjustment of the monorail or nail relation during the transport, whereby we need to maintain the parallel. Docking site non-union, joint stiffness, additional procedure required when docked to keep the fragment in place. This figure shows the technique of distraction osteogenesis using a monorail external fixator. A. Normal femur on the left and femur with a post-traumatic bone defect on the right. B. One pin was inserted into the proximal femur and another pin into the distal femur. A monorail external fixator was assembled to the two pins via connectors. C. According to the monorail pin insertion jig, two further pins were then inserted into the proximal and distal fragments, immediately followed by two pins into the transported fragment. D. Corticotomy performed. Bone transport, the blue halo, begins according to a predetermined lengthening regime. E. Bone transport is complete. Docking site union is secured and regenerate is forming. Illustrated by the orange halo. F. Monorail external fixator is removed and transported fragment is secured in the docking site using a small fragment locking plate. C. Intramedullary cable bone transport. Advantages of this procedure are: decrease the external fixator associated complication, all equipment widely available, improve cosmetic outcome. This picture illustrates the intramedullary cable bone transport. Cool, right? The disadvantages are: it permits only gradual weight bearing during the consolidation period. Increased infection rate. Docking site non-union. Not applicable to bone defects, excessive rotational deformities, or joint contractures. This picture shows the X-ray of intramedullary cable bone transport. For D. Plate-assisted bone segment transport. The advantages of these techniques are: fully remove the need for external fixation and the associated complication, improve cosmetic outcome. The disadvantages are: limited up to defect up to 8 cm, plate bending plus or minus breakage plus or minus nail jamming due to 3-point fixation, docking site non-union, increased infection rate with open fracture. E. Bone transport using a submuscular locking plate and a monorail fixator. The advantages are: submuscular position of the plate preserve the periosteal and endosteal blood supply. Opportunity to additionally compress and stabilize the transported segment at the time of docking using additional locking screws through the plate. Facilitates earlier external fixator removal. The disadvantages of this procedure include: increased infection rate, docking site non-union, need appropriate wound coverage to cover the metal. This picture illustrates the lateral view of the tibia with bone transport done using a locking plate and a monorail fixator. Finally, F. Acute shortening, acute fracture deformation, and gradual lengthening. The advantages of this procedure are: there is shorter union time, higher healing rate than bone transport, requires less bone graft than bone transport alone, lower rate of complications, and better radiographic outcome than bone transport. The disadvantages are increased surgical trauma with concurrent fibula should be shortened at the same time. Common peroneal nerve and distal branch injuries due to increased pressure on lower leg, mechanical axis deviation, foot drop due to limb shortening and muscle relaxation, limb pain and discomfort. Yay, we have reached to the end of this video. See you in the next one. Bye.